Can everybody hear me okay? Great. Thank you for coming to this symposium. It's PRP's been an interest of mine for a long time, about 15 years. And more than 10 years ago, I saw the concept of it being used as a filler, and I was always really, really dubious. I remember coming to one of these meetings where somebody had showed you can create clotting and activate PRP, and it generates volume. Well, we've sort of always known that. And one of the issues I had with that was actually what you were doing was forming a blood clot. You weren't forming anything that was going to last beyond what a hematoma lasts, about 4 to 6 weeks. So we never really adopted it, and when we tested it 8 years ago, 7 years ago, that's what we found. We found short-lived results. So when this product came along, the company were quite keen for me to try it, and I thought, well, what's the difference? And that's what I'm going to try and get across to you, what the difference between this is and what has been done before. It's been in the UK/Europe since about January, so I think we were the first to use it in Europe. But I didn't want to tell anybody about it until at least 3 to 4 months had gone by and we treated patients and we sort of saw the results. Because to me, I think if you're doing an aesthetic treatment on somebody, one, you need to know what the long-term data is. But secondly, I mean, if you're not going to generate, say, at least 3 months as a minimum, it's probably not worth doing, especially if you're charging patients. So I wanted at least some patients to get out to 3 months before I presented it. So I'll share some of our journey with you. So that's me. You can see I was wearing the same suit, so I'm right on point this is a really updated lecture. It's not an old one. And why is there a need for this at all? We've got dermal fillers, and it's probably heresy that I'm even mentioning in an aesthetic conference that we don't want to use dermal fillers. We've got all those nice companies out there, and to me, we've had dermal fillers for a long time. We know what they're capable of, but to me, there's a degree of, I would probably say either industry naivety or certainly clinician naivety behind fillers. We've now found, I've been using facial ultrasound in my clinic for 2-3 years, and all those things about fillers expiring, disappearing, 6 to 12 month longevity, 18-month longevity is all rubbish, okay? It's all rubbish. And there's now multiple papers out there published showing accumulation of filler over time. We've got filler in patients that I've spotted 7 years, 10 years after they've been injected. It's still there causing problems to them. So there's a lot of smoke and mirrors around filler. The other thing that we all know filler is capable of is collagenesis, but the collagenesis that filler generates, again, something that companies don't tend to tell you, is not your normal, type 1, type 2 collagen that we like to see in the different areas that we are used to seeing it. It's usually type 4, type 7, type 8, and other types, but basically scar collagen. It's usually what scar it leaves behind. There was a paper in 21 by an author who actually has documented quite clearly that about 10% of the volume generated by filler is residual scar, okay? And so if you've been in the game as long as I have, about 13, 14 years, I've now got those patients that I treated that long ago that are still coming to me, and I've started to see their slightly fibrotic skin and that shiny appearance in their skin, and I was slightly embarrassed to say I caused that, so that was me with the lack of knowledge. And it's one of the reasons I went into the regenerative medicine space about 5 or 6 years ago in quite a big way, because I thought there's going to be a better way. And we do, to me, filler's almost fourth line in my practice now. People get, there's a few things they get well before filler. If I use filler, they get small amounts, minute amounts, and usually as an adjunct to other treatments. So I use it quite late in the treatment paradigm that we have. There's also an increasing market demand for natural results and things that don't cause reactions, reduce complications. I think awareness is increasing. So there is a business element behind this as well. My clicker's not working, so I think we'll do this manually. So, as I said, it's not a new principle, but what's new about this product is what we'll cover. You can activate a PRP, you can turn it into a clot, you can actually have a clot that's almost a clot when you inject it. And some people have had the concept of an IPRF, an injectable PRF filler, a PRP product. Again, to me, you can't really cover this topic without at least alluding to a little bit of knowledge of PRP. So we are going to cover that a little bit. I don't tend to read my slides, so these are to some extent for your benefit. And we know PRP works in skin disorders. There's lots of data, there's randomized controlled trials, there's meta-analyses, there's systematic reviews. The issue is that PRP is not all of it's not the same. You know, PRP is not like paracetamol. It's not the same product and the same ingredients. There's not a standard generic. In paracetamol, the regulators tell you what has to go in it. So everyone who produces paracetamol, by and large, has the same sort of stuff in it. And certainly the active ingredients have to be standardized. That's not the case with PRP. PRP can have 20-fold variations from one system to the next in both growth factors and platelets. So you've got to have that understanding there before you start. So you've got to use something that you know is going to be value for your patients and give you the results you need for the indication you're using it for. So we know platelets are capable of secreting lots of growth factors, and it ultimately what they do is they signal for restoration of tissue integrity, whichever tissue they go into. And if that's skin, because that's your game, or hair, then that's what they will do. They will signal for an improvement and a normalization of physiology in that area, an increase in blood supply, and all the other beneficial effects that we know about. These are some of the common skin disorders. And PRP, it's a signaling molecule, really. So platelets break down, they send out lots of signals and cytokines, which are signaling molecules between cells. So some unscrupulous clinics actually call PRP a stem cell treatment. And that's because, yes, inherently there are some slightly increased numbers of stem cells within the plasma you generate. And also we know that PRP very reliably upregulates stem cell responses. But when I'm using stem cells in my practice, we're talking about millions of stem cells usually for a stem cell treatment. We're not talking about 10,000 becoming 20,000 or 30,000, which is what you tend to see in PRP. You see an amplification of 2 or 3-fold. If you say that to a patient and you want to be disingenuous and say, I've got 3 times your baseline of stem cells in this product, you're not lying, but you as a doctor or a clinician should know that that's not a stem cell treatment and you shouldn't be marketing it as such. So platelets and PRP generates an injury response, it amplifies that, it signals for support, and your body responds and the cells in that environment respond. So do we know what an ideal PRP is? That depends on what you're treating. Okay, so say we're talking here about skin. So in skin, we need enough platelets that they generate the response you want. But even skin is not uniform. So if you're treating rejuvenation, you may find a 2-fold concentration is perfectly fine. But we know that if you're treating, say, hair or a hyperpigmentation area or acne scarring, your concentration probably should be higher. And there are now dose escalation studies showing that sometimes you need to be at not 2-fold, but maybe 4-fold to get the best response for your patients. Number 2, what do you want to get rid of within your blood? You don't want everything in blood, otherwise you might as well just inject blood. Because all your platelets are sitting in the blood you take. You're not magicking new platelets into the system, they're in that tube. So why are we separating them in the first place? It's because some cells are not doing what you want them to do. Red cells being one of them, they are pro-apoptotic, so they generate cell death, inflammation, and they have a role. I mean, so when injury happens, you bleed first, and then you clot, and so they have an early role at signaling there's a big injury, and they generate that really pro-inflammatory response. But I think most of you, if you're clinicians, will know that Inflammation is inevitable, but you want to dampen it in most cases. You want to switch over from pro-inflammation to from catabolic environments to anabolic and low inflammatory environments as quickly as possible. You want to get that switch as early as possible. You don't want to create inflammation for a long time. Although again, my background is in musculoskeletal medicine and surgery, so occasionally, for say a chronic tendinopathy that somebody's had for 3 years, actually I may want pro-inflammation. So you've got to have a system that allows you to tune your response, and so you've got to be able to change your dose for skin or hair. And what that starts to suggest is that the clinician needs to know what they're doing, which I know might be a bit of a shock, but you'd be expected to do that if you're a GP prescribing blood pressure pills. I don't see why it's any different for PRP. Thankfully, the regulations are starting to tighten up. The MHRA did a consultation last year, and they are now calling this, because this is what it is, they're calling it point of care manufacture. And their question to doctors or clinicians is, if you're producing a product that you're sticking back into a patient, how is it that it's okay that you don't know what's in it? And the simple answer is, it's not okay. You should know what's in it. But obviously they can set that bar very high and say, well, you have to measure. And that's what I was involved in that consultation last year. And their original proposal was, you've got to measure what you put out. And that would mean everyone has to have a lab in their clinic, okay? And that starts to become challenging. So we know they always start off with a really high bar, and then they get realistic once they start to get, and the realistic element will be that they'll probably ask you, whichever system you use, is it a class 2B, soon to be a class 3 medical device? That will shut out a lot of the competitors out there because they haven't got data to get them anywhere near class 3. Is it because you're putting this into patients, you have to remember that, it's going into people. So you can't use tubes that have been tested by somebody in a diagnostic environment. They will produce PRP, we all know that. You can produce a PRP in most of these tubes, but they have not been tested for safety in patients. And so they don't meet that 2B or class 3 classification. The MHRA, as I said, they're upping their game. They've taken 10 years, 15 years to get there, but they're getting there. And what they'll probably also ask you to do is have access to a laboratory where maybe every 50th sample or 20th sample you send for testing to verify that it's safe, it's got no pathogens, it's not got any, and it's got what you think is in it. Okay, so I think that is not far away. So what else does blood have in that we're interested in? It has this leukocyte population. And we know that is not a homogeneous population, it's diverse. There are subsets within monocytes, macrophages, basophils, neutrophils, and they all do different things. So for some conditions we want them, and for others we don't. Generally, these are slides I've taken from Ryan Riggs's presentation, who's a colleague of mine in the US. And he describes a neutrophil as a captain. They fight your battles for you. They're pro-inflammatory, they generate catabolism, they generate inflammation. And so sometimes you may want that, but most of the time in the conditions we're interested in this room, we don't want that. So you want to minimize your catabolic and pro-inflammatory response. And then you've got the monocytes and different populations of the monocytes that form they're your primary stem cell stimulating cell. Monocytes, sounds a bit geeky, but they're my favorite cell at the moment, okay? So these things do amazing things, okay? They upregulate your stem cells. The stem cell function is dependent on your monocytes being intact and working. This is a really interesting cell, and you want to try and retain that in your PRP if possible. Lymphocytes are a slightly more diverse population. You want them sometimes, you don't want them sometimes. But it's difficult to choose. So ideally what you want is a simple system that tries to give you what you need within it. So if you can minimize your neutrophils, minimize your inflammation, then that's a positive thing. And again, neutrophil contamination, you can see on there that Eclipse and Tropper cells are actually the same system, and they have the lowest neutrophil contamination of any system. And that's what we measured in our PRP lab at the University of Birmingham when we measured them about 7 or 8 years ago. So, what is a poor quality PRP? It's one that doesn't give you what you need to treat patients. Not enough signaling, so not enough platelets, too much inflammation when you don't want it, and not enough anabolic factors like the monocytes, etc., that you want. There's a concept of a anabolic versus catabolic ratio, which I won't go into too much, but basically you want that switch over from catabolism that's inevitable. Every time you inject your patients, you're going to get that, but you want that switch over as quickly as possible to anti-inflammatory and regeneration. So I'm not going to labour that. We've got quite a lot to get through. So are we there yet with what we think is probably an ideal PRP system? I think I've probably convinced you that you don't really want red cells, not for your skin. You want as many platelets as you can get within your system. That's what we call efficiency, your yield of platelets in the system. You want to minimize your white blood cell counts, because a lot of them are lymphocytes and the minority are monocytes. But if you can then select between them, you want to get rid of the neutrophils, you want to retain as many monocytes as you can, and you want certain populations of lymphocytes. And I'm just sort of showing you the reason we chose tropa cells. We chose them after testing them in our laboratory, or tropa cells being Cellenis. Cellenis, tropa cells, Eclipse PRP, and my cells are different names for the same product all over the world. But in Europe, for aesthetics, is known as Cellenis, which is why it's branded as this in the UK. As I said, these are Ryan Riggs slides from the US, and it's called tropa cells or Eclipse PRP over there. So yeah, a little bit of confusion, but it's all the same product we're talking about. So it's as close to what we thought was an ideal PRP as we've currently got. I can't say in 5 years we won't have a better system. We may have a better system, and I'll be using that one then. But at the moment I'm using this one because of independent testing in our labs against all the other systems that we did. So that's sort of what it looks like, and we could. I'm going to go on a little bit now, hopefully beyond just PRP and systems, into the new product that we've got. You can get all of these slides off Roseanne around the product and the ratios and the concentrations and the purity. They're all available in the literature. So yeah, again, it's well established. I mean, Cellenis and tropa cells has been around for over 20 years. 50 countries are using it, millions of patients, and we know it's a reliable product. It's got all of the Class 2B, soon to be Class 3 certification, which it's important that you actually know how to check CE marks. All the companies out there tell you they've got a CE mark. That is usually provided by a notifying body, and it's your duty as a clinician to check that that is valid before you put it into a patient. Because if a patient has a problem, that's what you'll be asked to prove. And if you don't know how to actually find that notifying body, so all of the CE marks have a number, that number signifies a notifying body, you should be able to get online and find who that notifying body is, and that company's name will be in a list online. If you can't find that, they're lying to you. Because anybody who has gone through a CE marking or FDA approval, this is a badge of honor. Every company will want to throw that straight in your face. Look, I've got this. And any company that's sort of a bit reluctant to give you that it should be a red flag and giving you alarm bells. Because to me, if I ask you for your CE mark, you've spent £1 million and 2 years to get it, and you're reluctant to give it to me? Really? So be careful, because remember, the regulators, particularly in the UK, are reactionary. They're not proactive. They won't come and ask you until you get a problem. And when the patient complains, suddenly both your indemnity provider and the regulator will say, well, prove to me what you put into the patient, because it's on your license you're doing this. And then suddenly you're thinking, oh, and you go to the company and they say, well, we never gave you a CE certificate. And then you're looking yourself and you suddenly find there isn't a valid CE certificate, and you're in trouble because your indemnity gets withdrawn and the MHRA come down and close down your practice. So, and this is on the clinician. That's what I'm telling you, because I've seen people get into this trouble, and you won't get there until it's usually too late. You'll realize when it's too late. So you need to be proactive when the regulators are reactive. So there's a new product that was brought to me, and I thought, well, isn't this the same old thing that I saw 10 years ago and then again 6 years ago? What's the difference? So one of the things that worried me always is that people have been heating plasma for some time. The heat generated to break down the bonds between the plasma molecules and the albumin molecules and create clotting in a gel usually damages all your growth factors. So I'd always thought, yeah, you can generate a gel with heat, but usually it takes a long time. You do it in a slow bath and you build it up, and you have to wait 20, 30 minutes sometimes for that to actually turn into something useful. And then the consistency can be unreliable because it's patient dependent. So how do you create a reliable gel, but then retain the growth factors? Because you still want all those platelets and those growth factors that you want to use in the patients. How have they resolved that? And so, I was pleased to see that they've created a system where what they do is the PPP, the fraction that we perhaps discard, the platelet poor plasma, gets removed first, and that then generates leaves you behind your PRP fraction. And in this particular system in Cellenis, because of the high G spin, the high G4 spin, all of your platelets and growth factors are sat in that bottom 1 or 2 mils of plasma. So say in a 22 mil tube or 11 mil tube, your top 80% of your plasma, you can extract, remove, and you've not lost almost any of your platelets or your growth factors. So we leave that in there. The PPP is extracted, it's then capped off, I'll show you in a moment, and it's placed into a heater. That heater heats up to 100 degrees, but it's heating the plasma pore fraction. And at 100 degrees, it does it very quickly. So within 10 minutes, you've got a solid gel. And then you wait for it to cool down. You wait for it to cool down to below 40 degrees, so around physiological, and then you mix it with your growth factors, okay, which are now being put in at normal physiological temperature, which means that they're undamaged. So you've got all of your growth factors sat there. And what you tend to do is you start off with quite a gloopy gel, and then as you mix it and you do about 20 turns, you end up with a quite smooth, almost like a honey consistency. I was quite pleased to see this consistency, and again, hopefully we'll be able to show you that in a moment. You mix it together, and you end up with a product you're going to inject. So evidence-wise, does this work? There is data. There was an Egyptian study only last year showing 6-month outcomes on using an albumin-based gel, what they called a liquid fibrin gel, and they followed patients up for 6 months and actually showed objectively on measurements that you had retained volume, you had improved skin condition, etc. And the key to it is you've got to retain your growth factors. You've got to retain your growth factors. So when we measure, I think the concept of a matrix and a scaffold most people already buy. That should be there. And what you do is if you can retain your growth factors with a matrix and a scaffold, you end up with a slightly slow release system of growth factors. And we know when we've measured it that most of the time your growth factors peak around 48, 72 hours. That stays high in most PRP, depending on where you deliver it. Obviously it's different in a joint, maybe different in skin, maybe different if you're putting it in a tendon, for instance. All of the areas I use it. But your growth factors tend to peak in skin at about 48 to 72 hours. They stay high usually for about a week. So you've got somewhere between 4 and 7 days, 4 to 8 days. But with a slow release matrix type system, it's been measured to stay high for anywhere up to about 12 to 14 days. So we know they stick around for longer. And you're hoping then that your overall dose of growth factors is higher that you're delivering to the patient. That's the theory. That clinically has not been proven, as in nobody's actually measured specifically on patients that you get a superior outcome. What they've measured is the growth factor response. The growth factor measure. They've not shown that it corresponds to a clinical outcome. So that's a study hopefully we'll undertake in the future. These are just different growth factors, just showing that we get an amplification of transformed TGF and other collagenesis generating growth factors over time. So we think having a scaffold or a matrix is beneficial. That's a take home. But if you're destroying your growth factors in the process of getting there, that's not good. Whereas in this system, you're not doing that. I don't know if this will work actually. So I've got a slight backup plan because we're using it's a YouTube video which I'd like to share with you. Hopefully this will work. Oh, we've lost the share. Ah, magic. Let me, it's a short video hopefully, but it gives you an idea. So this is the two products now that have been produced. You can see the tiny amounts of very rich, that's highly concentrated PRP, about 10-fold, 8 to 10-fold is what you're dealing with. And you mix the two together and you end up with this product that you can then inject. I decant it because it's quite viscous. It is very viscous. You can't put it in unless you're using a 1 ml syringe. You won't get it in with a 2 or a 5 ml syringe. That's just me. I use ultrasound guided injections. So that you can see this product, it comes out like a cloud, it's visual, and you can see it being placed in tissue. Use a cannula. I use a cannula, ultrasound guided. We got into the right layer, so we're doing a tear trough here. And the beauty of this product is, it's unlike filler, you're not worried about tyndall. You're not worried about, so I put it in all the layers. I go superficial above the muscle, below the muscle. So I'm generating volume, I'm generating skin regeneration, I'm putting in all the layers. And I haven't, in the patients I've tested this on, had any problems. Sorry, buddy, if we can switch back to the PowerPoint. I don't know if that tells anybody what my YouTube feed's like normally, but one of the beauties of this product is the areas that you would normally avoid placing filler, you don't need to worry about. And so I tested that intentionally with our first patient cohort. And I'd like to share one of the cases with you. So, 62-year-old female, and attended clinic, wanted natural, not synthetic results, has had previous maxillofacial surgery and has actually got a plate sat in the maxillary area. So another reason to potentially avoid something synthetic. You know there's going to be some scarring there. You know that if they get an infection, it could be a disaster. So again, one of the beauties of PRPs is anti-biofilm. It resists biofilm, resists infection, so it's antibacterial. We've shown that in diabetic foot ulcers and other wounds and areas that we use it. And it's one of the reasons that people who use PRP, or the advocates of PRP, will tell you that they sometimes mix PRP with HA. You've seen that's been around for quite a few years. I don't do that. One of the reasons is, I just mentioned point of care manufacturer. If you do that, you don't actually know what the PRP is doing to the filler, and you don't know what the filler is doing to the PRP. So you've now become a manufacturer of a new product, so it's entirely on your license. Both the PRP manufacturer and the HA manufacturer will say, nothing to do with me, Governor. If there's a problem, it's all on you. You've now changed our product. And that's how the regulators see it. So I do use them at the same sitting, but they go in separately through, a separate syringe, and usually a different layer. You can use them together, no problems. I know people who swear by the fact they've had less problems with granuloma formation since they started doing that. And that's why, I think I saw somebody doing that on here, on the stage about 5 years ago, telling everybody that they were mixing the two together and getting better results, because they've got the growth factors alongside the filler as well. And so there is some evidence that HA does have a matrix type property, will hold on to your PRP and your growth factors will improve as well. So you can see the patient. So these are my pre-treatment shots. You can see laxity, ptosis of tissues, some volume loss, yes, some abnormal skin tone, jowling. So usually, she's pretty good actually for 62. This is post-lockdown, but we've got those are the pre-treatment pictures. I did a mid-treatment shot. So this is about halfway through, just to show you the difference between one side and the other. Like all people, she's not completely asymmetrical. Her left side, so the treated side, is the weaker side clinically. She has more ptosis, more lines, more drop and more volume loss on that left side. And I started with that side, and then we moved on. And you can look at the volumes. I mean, 8 mils. That's actually not that much of this product, because from a 122 mil tube you can generate 12, 13, 14 mils of product. And from an 11 mil you can generate about 7. So I had plenty of product to play with. So, and again, because I was putting in so many layers, I was quite liberal with it. Her chin's been augmented, so we've done jawline, chin, cheek, tear trough, medial cheek fat pad, lateral cheek, buccal fat pad. So quite an extensive treatment already. And that's the full treatment pictures. And to me, she was very happy. And this lady's lost, on an aging parameter, about 10 years at least, probably there. So she looks just much fresher, much younger. Volume loss has improved, and this is immediately post-treatment. So within an hour or so, we kept her in clinic. Those are the side shots or oblique shots, and that's your laterals. So she was very happy. It was a moderately uncomfortable treatment, I do have to tell you that, because I put 16 mils in. So we're going into multiple layers, 16 mils, and there's a pressure effect. And you tend to find you're putting small bits in, it's fine. You put a bit more in to generate volume, and they get a sort of baroreceptor response. It's volume. I may have slightly overdone it, because my worry in the back of my head was, I'm going to lose at least half this volume. I already knew that. I thought I'm going to lose half this volume. So a bit like when we do fat transfer and fat grafting, I'd sort of thought, I'll over-rig it slightly because I'm expecting loss. And she's one of our very first patients to ever get treated with this product, and probably the first patient in Europe.
How long does it take to get the volume loss to get the volume down?
Yeah, good. So thanks, Josh. So that's the next slide. You're going to see that. So this is 4 weeks later. Okay, so 4 weeks later, the picture on the left is pre-treatment. You can see on the right, a month down the line, she's lost all the swelling per se, but I think you can still quite clearly see the volume there. Compare the picture on the right to the left. So the volume is still there. She looks much more voluminous and natural, and the volume is still better. And to me, I mean, I don't know how well you can see it on here with the lights, but her skin quality looked amazing. She was really, really happy at 4 weeks. She had this glowy, dewy skin, pigmentation reduced, discoloration had reduced, even rosacea, she told me, was better. She's getting better. I don't know whether that's purely a volume effect, rosacea can improve, but her skin just looked better. So I thought, okay, well, 4 weeks, we still haven't hit that magic 6 to 8 week mark, so I hadn't told anybody we were doing this at this stage. So then I got her back at 2 months, and again, pre-treatment there, post-treatment here. You can still see the volumes there. Some of the jowl is back, but that cheek enhancement, volumes there. Skin still looked fantastic. So she was reporting, my skin's amazing, still looks really, really good. But because she had such a great result, and I'd put so much in her at the beginning, she was now sort of saying, well, I really liked it when I looked 10 years younger, 6 weeks earlier. Can I have some more? And then I thought, well, I don't know is the answer to that. So, and my view is with PRP, to get your maximum response, I normally say to patients, you're going to need 2 to 3 treatments. Everybody over the age of about 30 needs 3 treatments. You call it in my hands, I call it the ultimate mesotherapy. Your skin is as good as it's going to get if you've had 3 lots of targeted PRP of a good concentration, high quality PRP. It doesn't get any better than that. It almost doesn't matter what else you add to it. Yeah, you can have a skin regime and retinols and all those other things, and you can spend 6 months getting that result, but you don't get improvement in skin density, elastin, volume, actually thickening of your skin like you do with PRP. So PRP is one of the few regenerative treatments that you can do for your patients that actually truly steps the clock back. We know that from all the data and our own results. This is at 2 months now. So again, I'm watching carefully. And at this point, she wants retreating. So I've sort of gone, you still look really good to me. So why don't we wait a little bit longer? And so I go a bit longer, we get to 3 months. And again, to me, her volume is still better. The tear troughs are still better, but you can now start to see that weaker side of her face, the left side, the tear troughs coming back, the ptosis is there a little bit more, her lines are a bit deeper on that left. So she's now getting to the point where she's saying, I'm still happy with the skin quality, but I want that volume back. So can I have another treatment? So I then exceeded and I said, look, we've got you to 3 months, let's do another treatment. So we then did a second treatment. And the second treatment I learned she needed much less, because we already built on the previous platform, and at 3 months, to almost get her back to that 10 years younger look, I actually used about half the volume. So it was 1 tube this time, not two, 9 mils, and we got her back to where I was happy and she was happy. And she's now out to 4 months, so this is my oldest case. So we're out to about 4 to 5 months in our experience. I've done about 8 or 9 patients. Our plan is to get to 10, and then we'll publish a case series. And once we get to 20, we're going to start taking some objective, so Canfield or observe skin measurements, so we can get this published. But to me, up till now, I'm really happy with it. The patients I've treated are really happy with it. On top of the volume that is lasting for at least 3 months, the data suggests should go on for at least 6 months. And I'm pretty confident from what I've seen at 3 months that we will have a visible, measurable response for at least 6 months. Because I think this lady was still at 50% of what we'd restored at 3 months. But she wanted to go back and get more. And I think that's probably what we'll find is we'll end up doing 2 treatments or 3 treatments to give them probably about a year. And then you maintain it with an annual treatment, which is volume and growth factors, and you just get that skin rejuvenation as well as the volume response. And that's probably where we're heading with this treatment. And like I said, I'm hoping I can share the larger series with you maybe in 6 months or so of the rest of the patients. So what have we learned? I mean, quite a few lessons. One, the first treatment, I had the patient in clinic for about 2 hours. We prepped them. We put on a local anesthetic cream. And the first treatment, I apologize for the typo there, there's an R missing, but about 90 minutes. It took me about 90 minutes to do the first treatment. But that's what I was learning. One thing I learned was that when the heating block heats up your PRP or your plasma and gives you your, so this is the actual, so this is the solid. Okay, I don't know if you guys, can we switch over to camera? We're on camera, so I better put my gloves on. So this is now solid. So you can see this was PPP. It's no longer a liquid. If I turn it over, it's solid. And it's still fairly warm, so that's probably about 45, 50 degrees. But it's heating down cooling down quite quickly. It's been off for about 10 minutes. And one thing we hadn't factored in, I thought, well, the guideline was measure the temperature, start mixing when you're below 40. So you're heading to about 37. So I waited till I was at 37 degrees for the first one. It actually took about 25 to 27 minutes. So nearly half an hour for it to cool down. I've learned since then that you will put it in the fridge and in about 8 minutes, it cools down. So it's about 8 minutes in the fridge or 25 minutes at room temperature waiting. So you want to shrink that treatment time down. And then you've got the PRP that you left behind still in the system. So you then do the resuspension step where you mix that. So now all of the platelets that were sat in this tube are now mixing in with my PRP. And once you're happy with that mixing step, that you've got your platelets resuspended, you then extract all that residual. I don't know if my fingers are in the way, but yeah, I'm now extracting the PRP into a separate syringe. So you've got the PRP that you want. The ratio I found that sort of works is about 20%. So you're aiming for about 10 of this to 2 of this. And that seems to give you a good mixture that gives you a nice firm texture. And again, so between the 2 syringes, you've got a sterile stopper, and you use a lure-to-lure connector If you haven't got a to lure, then a three-way does the job as well. And then you go from one, I don't know how well you can see that, but I'm now injecting the solid into the liquid. And it sort of almost looks like butter. Butter, sort of at the moment. With solid, you can see solid mixed with liquid. But as you actually go side to side with that, it just smoothens out very, very quickly. So within about 10 turns, it turns to a nice smooth product. And then as I keep doing this for a while, usually at least 20, 30 times. And then you end up with this nice gloopy, almost, like I said, a honey sort of texture. It looks like honey, you know, and you know, it's got that sort of manuka, buttery type texture. Almond milky. And there we've got this nice smooth product, and you're then ready to transfer that into your 1 ml syringes, and then via cannula or needle you place that where you want to place it. Again, it's you know, I could just sort of maybe show you that it's quite viscous. You can see it comes out as a solid and stays as a solid. I can probably, don't know how well I can. That's sort of what it looks like. So it's like yellow Profilo. Okay. And that's the consistency it's at, and it generally, I mean, as I said, you saw from me, I was using it with ultrasound to generate, so I could show the volume. I thought, I wonder what it looks like, and you can see it consistently. And I've got videos of it, you know, where you've got a deficit, you know, you've got a defect and a hollowing, and I've placed a deep cannula in, and then on video, as we've injected it, you just see the hollow disappear, and it's lovely. And then you need to massage it in. So if we can go back to the slides, great, thanks guys. So one of the other lessons we learned, so you need a surface thermometer, so you need to be able to measure the temperature in the tube, otherwise you're guessing. You know, does it feel warm? Use a fridge to cool down the gel. It cools down much quicker, saves you a lot of time. And then massage after the treatment. You want to actually massage liberally. With the first couple of patients I treated, I thought, well, it's so smooth and it's going everywhere. You always do a little bit of a massage, but I didn't encourage the patients to massage. And then what I had is they were telling me they've got lumps. And I thought, okay, well, it's a natural product. It's not going to generate lumps. But what I was doing is I was being very liberal with going in. I was saying, well, this is PRP, so putting in like 4 mils in one area. You know, I'd never do that with filler. So they were, you know, 4 mils, amazing response. And then they were saying to me, well, I can feel a bump. But for most patients, by 2 weeks down the line, they'd all gone. And they weren't visible. They weren't visible. So the patient could say, I could still feel something. And I know, you know, with my, you know, like filler, I said, you know, give it a few days, it'll all go away. But I've actually found that you need to tell them it might be a few weeks. And now what I've actually started to say to the 5th or the 6th patient I've now treated, well, from the 5th patient onwards, I've started to say to them, actually, just do not the same day, because I do that in clinic, but the next day, do some gentle massaging. Do some gentle massaging yourself, and then you'll get less issues with bumps. And they can just smooth it out. They don't tend to affect it, and you don't get migration of this product. It embeds, and it will integrate very quickly into fat, into tissue areas. And if it migrates a little bit, who cares? You know, it's not filler. It's sort of it can be in multi-planes, and that's one of the beauties of it. I can place this in all the layers I want to put it in, without any risk or concern. I'm a big cannula user, so I suppose, you know, I don't advocate putting it into vessels, but the consistency of it is such that if you were to get this onto a vessel, it will not create compression. I don't think vascular occlusion is very likely with this product at all. And I, under ultrasound, have placed boluses right next to arteries and veins to test it. And you actually just tend to find, as you massage, you see the vessel will go under pressure. As you massage, it just rebounds, because it's a very soft product. Like I said, it's more Profilo than filler, is the way I sort of think of it. It's mobile, and it spreads out. Like I said, honey is the sort of texture that it has. And that's why you can use so much more of it as well. And on top of that, you've got the regenerative properties of all the growth factors that are still there. So like I said, all the patients I put it in, their skin looks amazing. You know, from about 2 to 4 weeks, you see an obvious difference in their skin, and they notice that as well. So, in conclusion, you know, if you, the treatment time you saw initially, I was sat there thinking, if this takes 2 hours per patient, you know, to do heat up, wait 25 minutes to go down, then I'm putting in 2 injections, I'm doing 15 mils of volume. How do you charge this? Because we're going to have to, you know, this is going to be really expensive, and then if I have to do 2 or 3. But I've now sort of worked out I can get from 90 minutes to about 45 minutes. The second treatment will be much quicker, gentler, less volume required. And so I suppose you price it depending on your market, but it is to me cost effective for the right patients. Those patients are after definitely natural results, want to avoid filler, are interested in natural responses and healing, growth factors, great skin and tissue augmentation without all the risks associated with filler, and not have the risk of scarring. You won't get scarring from this product. You won't get fibrosis from this product. It's a natural product. It's purely autologous. It's just your own body's healing volume, plasma proteins, albumin gel that is creating all of the results. You can combine it with microneedling. I haven't yet for these patients just because they're study cases, so I didn't want to muddy the waters by giving them different treatments. But I ordinarily, when I'm doing PRP, I combine it with very shallow, you know, 0.5 ml microneedling, and that enhances your result and minimises your inflammation. And I'll probably do that for these patients in the future. But at the moment, their skin seems to be doing really, really well as well. Is that the pigeon or is that the hawk? Is it the hawk or the pigeon? Ah. There's a hawk somewhere hunting pigeons down as well. So I think, yeah, we're on to questions. Any questions from anybody? We've got the last sort of 5 minutes or so. Okay.
Are you injecting purely just for volumization?
Am I?
Are you injecting PRP just for volumization? Because obviously putting on top of it, you get all of the skin benefits.
Yeah, so yeah, good question. So I think the question is, how do I apply PRP? Do I do it topically or inject it? Yeah. Yeah, exactly. So to me, you know, if you know, we know that synergistic treatments and adding treatments give you the best results. I think everyone knows that now, that combining microneedling with a bit of PRP and a bit of volume or a matrix and a skin regime, that's going to give you your patient's results. Okay, so we all know that. And I think when you do this, I inject PRP because if you apply it topically, it works, but you lose 80% of your growth factors. Okay, they just sit on top of your skin and disappear. They're what you, yeah, because the majority of the growth factors will not penetrate. You'll get 20-25%, which is why it works. Microneedling works anyway. So microneedling works. You create channels. You drop your PRP on top. The so-called vampire facial that they use in the US. But your 20% of your growth factors will probably penetrate. The other 80% will get washed down the sink. So we inject it preferably, and we will apply the PPP topically with microneedling and use it as a glide. And we find that's given us much better results, almost pretty much 100% satisfaction with our patients if we do that method of doing it. And this really is, as I said, I probably will bring in microneedling and probably that topical PRP or topical PPP in the future, because we do that routinely usually. I'm just not doing it in this population, so wanting to see what was going to happen to the skin. And it seems to be doing really, really good things with the skin. The skin laxity, well actually this will improve your skin laxity anyway. You can see it is doing that in these patients. Their skin laxity is improving because we know the growth factors, if they penetrate, if they go, and you're putting them in at multiple layers, so you're not just addressing laxity of the skin, you're addressing laxity, you're enhancing your fat pad, you're enhancing your, and so growth factors in your fat, growth factors in your muscle, growth factors in your bone, you've got an element, and remember PRP generates a common tissue boost signal, whatever tissue you put it in. We use it in fractures. So you will get an enhancement of tissue every layer you place it. But yeah, you get both responses in this. But I think you would probably get an even bigger response if you put something on topically or injected it in as well. So, what I was saying with this product, I don't worry about the layers. I'm putting it in 2, 3, 4, wherever I want to put it, I put it, which is unusual. Obviously, most products you've got to think about where you're putting it. And I'm not here. I've put it superficially in the tear trough, above the muscle, just below the skin. I've put it deep to the tear trough. I've then gone into fat pads. I've gone in just subdermal, etc., etc. So I've gone into multiple layers and placed it, and that's why I've got that sort of pretty stunning result in that lady on the first treatment, because I haven't worried about where I'm putting it, because it's not going to cause a problem. So multiple layers with a cannula. Yeah. Another question? So Roseanne's here, who's the rep for this company, but the kits, you have to remember you're right, it's about fitting. Centrifuge has no technology in it at all. It's just a G-force generator. So as long as your tube fits neatly into a centrifuge and you generate the right G-force for that product, you can use any centrifuge. I've got 7 in my lab, and we intervene them. But you'll find that the 22mm tubes are unique to this system. So there's an 11mm tube that will probably fit in lots of centrifuges and will give you about 8 mils of volume, but the 22mm tends to only fit in this system. Unless you've got a lab with lots of centrifuges like I have. Mine will fit in about 3 of my centrifuges, but not in the other 4. So you probably do need to get a centrifuge that is specific to this system most of the time. But the company are not bothered what centrifuge you're using as long as you do it at the right G-force.
There's only one size tube, which is the 22.
No, there's an 11mm and a 22mm. There's 2 of them. The stand's over there, and you can go and see the tubes, bottom left. But that's a 22mm tube. There's an 11mm as well. So it depends how much volume you want. You want 8 mils, or do you want 16, 17, 18 mils? From 122, you'll get about 13 to 14 mils of volume. So quite a lot. Rubina?
You know, with the commercial, first I have to say it's a presentation is attracting me a lot, because I've been doing PRP for the last 17 years now, and I do a lot of PRP for chronic pain conditions with absolutely brilliant results. Now, I just wanted to check that when you use the commercial fillers, you've got the cross linkages which keeps it in place. Now, this is purely natural. Do you think it's going to start sliding gravitationally in any direction?
I don't know, because just if you extrapolate from wound care, where we use PRP gels and plasmas and matrices, you don't tend to use it. Integrates. It's a natural product. It integrates into the tissue you put it very, very well. And like I said, what I've actually found is, if I did any other treatment with this level of volume, the amount of swelling you get will be enormous. And I was slightly panicky when I did the first 16mm treatment. I thought, when she goes home, is she going to come back with edema everywhere? And actually, it was the reverse. Within 2 days, everything had gone. All the swelling had gone. So because of the growth factors, and we know the healing properties of PRP, their swelling diminishes really, really quickly. So actually, 2-3 days, virtually all the swelling disappears.
So you don't think there's an inflammatory effect of having the swelling initially, and then as the inflammatory effect starts settling down, the swelling settles as well?
Yeah, the swelling settles much quicker than other products you'll use that generate inflammation. That's what I found. But I always found that with PRP. With PRP treatments, inflammation settles down much, much quicker. We've always known that. But it's the same with this. I was worried with the volume I used, whether I'd get lots of edema. Didn't really get any. And all of the patients I've done it in have reported the same. Within 2-3 days, all of their swelling is gone, and they've just got the volume there, and they're really, really happy by about day 2.
So if you got more volume loss in certain areas, would it sink more into that area? Will it find its way? Or
Well, I say, you know, most complications are clinician delivered. So if you know where you're putting it, most anatomical places are fairly discrete. So if you place it submuscular and you place it in a discrete pocket, you don't tend to find it goes everywhere. It will stay in that area. And that's why one of the things I wanted to measure was, does it stay where I place it? And that's why I did the ultrasound guided injection. And I found that I'm injecting and I can see it swell the area, and I can see a physical uplift of the tissue, and that stays there. And that's why a month later when I'm measuring them, they've still got that volume. So it hasn't migrated. When I look for it on ultrasound 2 weeks down the line, 4 weeks down the line, which I have, I can't see it. So it seems to have integrated completely. You can't find it on ultrasound as a product. Whereas HA, like I said, I've seen 7 years down the line, I've seen HA still sitting there.
and then you said, sorry, I'm taking up more time. And then you mentioned about using another product aggressively, like the HA. Have you noticed after 2 weeks that the HA made any difference compared to the plasma there? So that stays a bit more swollen compared to the plasma, or do they just evenly distribute between the
Well, we're never brave enough, or I'd argue stupid enough, to put that much HA into somebody. So I've never, you know, my biggest treatments, I'm very conservative with HA, 2 mils, 4 mils. I've never gone beyond 6 mils in a patient. And that's based on, actually, if you look at literature from 15, 20 years ago, it shows your biofilm, granulomatous reactions, all climb significantly after 6 mils. The companies don't tell you that. It's not in any of their literature or their IFUs.
all this comes with experience?
Yeah, you know.
Thank you very much.
Thanks, guys. So we're slightly, is it lunch now, or we got time? For the lips? Good question. I haven't been brave enough to put it in lips yet. So that's my next project. So I avoided lips, I haven't put it in lips. I put it periorally. I did it around the mouth for fine lines. I've put it everywhere else. I've augmented chin, volume, crepey lines, into cheek. You know, all those lines that you normally worry about adding volume or weight to. That cheek area that everyone says don't put filler in because they're going to get heavier. Just go with it. I'm putting it in. It integrates, it disappears, and their skin rebounds. So, but I haven't done lip yet. So that's to be confirmed. Yeah. So fat transfer is a different. If you're talking about fat, with fat transfer, you're trying to achieve living cell integration. So in theory, it's a permanent filler, isn't it? So if the fat cells stay alive, they graft, and you get engraftment, and they stay alive. And if you get living cells, you've now got something that you didn't have before. And we use that. We tend to find engraftment cases are unpredictable. That's part of the issue. It can be between 30% take up to about 70%, depending on your technique, the grafts, whether you mix it with PRP, how it's delivered. Huge variation. So we do use that, but it's to me it's a much more expensive treatment. It's a little bit less dependable, and it's higher risk. And you may have to repeat it, because if they lose more on one side than the other, you've then got asymmetry to deal with fat. Because if you get more engraftment on one side, they're going to notice it, and it's not going to be a short-term thing, it's going to be a long-term thing, so you've got to come back and do the other side. So it's a higher risk treatment. To me, I always start safe, cheap. Safe and cheap, and then to me, I'd always give this to a patient before I went for fat grafting. Sorry, Rubina? So cost per session. Well, this product costs the same as your Cellenis tubes. You just need a bit more equipment. So to you, the cost isn't any different, other than in the treatment time. There's no additional costs, other than a tiny bit on materials, but Roseanne can tell you, but it's not, as far as I'm aware, it's the same cost to you. To the patient, you've got to decide where you position it. I'd suggest somewhere above PRP, but much less than fat grafting. You know, I haven't even decided that yet. I don't know where I'm going to position it. It's going to be above PRP, but maybe only about 50%. I think we're at lunch now. Thank you, everybody.